Let's kind of get the introductions going. First of all, on behalf of Promed Hospitals, thank you so much for taking the time to participate in it. It means a lot. I'll start with the international faculty. Dr. Shripal Bangalore is a good friend, but he is, more importantly, he's a professor of medicine with, at the New York University School of Medicine. He's director of cardiac cath lab and director of complex coronary intervention at Bellevue Hospital. He's also director of research for the cath lab and director of cardiovascular outcomes at NYU. Does a lot of complex PCI, including CTOs. I do not want to start listing his publications because that'll take an hour and a half and we'll be done. He has published more than 400 articles in pretty much every major journal on planet Earth. Also as a principal investigator of the ischemia CKD trial, a recipient of the Gregory Braden Memorial Interventional Cardiology Fellow of the Year Award from Sky, and the famous Doug Zipes Distinguished Young Scientist Award from the ACC. So truly an honor. Thanks for joining, Shripal. Moving on to Dr. Quan Lee. He's an associate professor of clinical medicine, has been on faculty at the University of Arizona, Tucson since for more than 10 years. He got his medical degree from the Trinity College in Ireland, and he completed his residency cardiology fellowship in IC at Mayo Clinic. And he is board certified in a lot of stuff: internal medicine, cardiovascular disease, echo, interventional cardiology, and endovascular medicine. He is the cardiovascular medicine line director for Banner University Medical Group and the associate chief of cardiology at the Sarver Heart Center and associate program director for the cardiology fellowship. He's also the governor for the ACC Arizona chapter. Okay, I'm going to stop there because it can keep going on and on. Dr. G. Sengutuvelu is an interventional cardiologist, a senior interventional cardiologist at Apollo Hospital, Chennai. He is a leader in not just in South India, but I would say all of India in terms of complex PCI stenting, structural heart interventions. He, again, multifaceted, does everything in interventional cardiology. He also is from my medical college, so and is my senior, so it's great having him on. He did his interventional cardiology training at with Dr. Mary Claude Maurice, and he has done more than 15,000 cath lab procedures, published in several journals, including Eurointervention, JACC, Indian Heart Journal, Heart, name it. Again, he's been there. He is, again, a co-director of India Valves, founder director of Imaging Physiology Council of India, and he's on, the board member in several leading organizations, and I'm going to stop there. Dr. Sridhar Kasturi is a senior interventional cardiologist and is originally from the United States of Andhra Pradesh, but now stays in Telangana. He has done more than 18,000 angiographies and several thousand interventional procedures and more than 100,000 echocardiograms. He has been awarded as the best cardiologist for outstanding contribution in the field of cardiology from Council of Industrial and Trade Development. He is truly one of the most talented interventional cardiologists I've ever come across, can pretty much bail most cardiologists out of trouble in almost any situation in the cath lab. He has done one of the first EVARs in the country, and I believe it was the first in United Andhra Pradesh to have done it. He has done a lot of charitable work, including lots of free health camps, and he's presently working as at Sunshine Hospital in Hyderabad, and is also the head of the Department of Cardiology at Chalmeda Ananda Rao Institute of Medical Sciences. We have Dr. Pratap Kumar, again, a dear friend, one of the founding members of the IJCTO. He is not just a fantastic complex PCI operator, but also an entrepreneur. He is chairman of the Mediterranean Hospitals. He did his interventional cardiology fellowship at the University of Turin in Italy. And he does, again, almost everything in interventional cardiology. He is presently he's based in Colum, but he probably is one of those people that travels more than I do to do CTOs pretty much in a lot of places. He has won a series of awards and recognitions, including the Excellence Award by Vivekananda Samskriti Samiti, Times of India Awards, and also awards from the Amrita Institute of Medical Sciences. And last but not least, I don't know if Dr. Ashok Seth has joined us, but again, He is an interventional cardiologist in India, and almost every interventional cardiologist in India has been trained or influenced by this legend. He has done over 50,000 angiograms and 20,000 plasties, and is included in the Limca Book of Records for this honor. He is also a Padma Bhushan. He got that in 2015. And he got the national award from the Republic of Spain. I believe it's called the Officer's Cross Order of Isabella the Catholic. Again, his list of awards, I can keep going on for the next hour and a half. He's also the Mason Sons Award from Sky 2010. He is he's a voting selector of Sky nominating committee. He's on pretty much the every board, every major organization on planet Earth. He is most recently, he is also the president of the Asia Pacific Society of Interventional Cardiology. Guys, it's truly an honor. Thank you for taking the time. Really, really appreciate you guys joining here. So let me move on to and by the way, he was instrumental in kind of getting me to India. I got to say that. And had the pleasure of working with him for almost an hour, for a year plus.
Yeah.
Had some great times together. So thank you guys.
Wonderful times together. Wonderful.
Thank you so much. Let's move on to the first talk. I'd like to invite Dr. Sangutuvelu to deliver the inaugural talk today.
Thank you, Arun. Thank you. Very nice to be here, and with also esteemed faculty. So my talk would be on bifurcations.
Hello, Dr. Sangutuvelu. How are you?
Yeah, fine. Thank you. Good to see you. And so it's very nice to have.
Yeah, good to see you.
Can you see my slides, please? Yes. Can you see my slides?
Yes. Now we can.
Okay. Can I go ahead, or you want to say a few words?
No, all I wanted to say was it's just a pleasure to be actually here with Arun. Yes, it's been tremendous time that we spent together. I mean, I met him in Seattle and spent some time and we talked about his return to India. It's just so wonderful to actually have him back in this country, and not just back in the country, to have contributed immensely to Asia Pacific region and India. And I think it's been a wonderful time that we spent together. I had a great love and affection and a mutual respect for each other's capabilities and skills, and have tied up very, very, I would say with a lot of affection to create successes in some very difficult cases together. So I always miss him. I'm so happy he's opened up a great center in Chennai, but I wish he hadn't, because then he would have spent more time with me.
Thank you.
Thank you, Arun. I think you're doing very phenomenal work, and it's really nice. Arun is in Chennai, so we do sometimes do work together, and it's fantastic. And I wish his Promed Hospital does very well. So I will start my talk now. So it's about bifurcation PCI, what you should know. So I'm going to talk about basics of how a bifurcation PCI should be investigated. We know that about 15% of our angiographic major pictures are come out with a bifurcation lesion. So one should be familiar with how to approach a bifurcation lesion. By definition, bifurcation lesion is where a coronary artery narrowing occurring adjacent or involving an origin of a significant side branch. So what we mean by significant side branch is a branch which you don't want to lose in a global context of a particular patient. Doesn't mean the size or mainly the territory of supply and how the patient will respond if the branch closes. So moving on, classification of bifurcation, though there are a number of classifications to be described, more commonly accepted is the Medina classification, which is quite simple to understand. We know that when there is proximal main branch disease, we give us 1, distal main branch will be 1, and the side branch will be the last one. So 1, 1, 1 is true bifurcation lesion where all the 3 are involved. Similarly, 1, 1, 0 where there is no disease, the side branch, and so on. So it's quite easy and easy to definitely classify these bifurcation lesions, but these have limitations. This does not take into account the size of the lesion or the size of the lesion or the characteristics of the lesion or the angle. So many of the things are left out in this classification. The next classification is on the technique of bifurcation stenting. This is one of the most accepted classification, which is MADS classification. MADS. It's again simple to understand. M is again where you stent the main branch first. Start with the main branch. A is across the main branch, across the side branch. D is distal of the main branch, and S is side branch first. So what generally we do is we more commonly use the across the side branch, that is the provisional stenting, which can again go on to either additional stenting with a tap or a culotte. Side branch stenting is the next common form of quite common form of approach where we start with the side branch. Very often the DK crush is the technique which is used for this technique. So when assessing a bifurcation lesion, it's important to remember these three important things. When you look at it, look at the three diameters of a bifurcation: the proximal, the distal main branch, and the side branch. And we have several laws. The Murray's law, now it's simplified with the Finet's law, which is just the when you add both the distal and the side branch, both the side branches, and the 2/3 gives the main branch diameter. This really helps us to know the size even without imaging. Just by looking at the angiogram, one can assess the true diameter, and it will help us to plan the procedure well. Next important thing is to look at the lesion length, the plaque distribution, and also the angle of bifurcation. The angle of bifurcation helps us. For example, if you have a very 90-degree angle, the chances of plaque shift is much lower than in a very acute angle. Also, the approach or the technique for bifurcation PCI depends to extent on the branch, on the division, and the angle also. So one also has to look at the proper angiographic weeks, taking into view there may be some foreshortening. So definitely imaging will help. I will talk about it a little later. So it's important to choose the size of the stent based on the distal diameter of the main vessel. So main vessel distal, the distal part of the vessel, not in the proximal vessel. Stent is always done because we know if we size to the proximal vessel, this is the carina. Carina is the branching point or the flow divider. So if we take a stent based on the proximal diameter, we can cause the carina shifting and pinching of the side branch. So it's important to choose a size based on the distal diameter of the vessel. But the problem is when you choose a size on the distal diameter, you have proximal malapposition. So you have then the risk of malapposition is like when you rewire, it can go abdominally, it can cause other problems. So I talk about it. So it is important to do a port or proximal optimization where you take a short balloon and post-dilate the proximal part of the stent. So choosing a port balloon is very important. Once you choose the size of the stent, it's important to remember that we need to do a port and according to have a sufficient length proximal to the side branch, at least 8 millimeters, where we have most of the balloons we have 8 millimeters and sometimes even 6 millimeters the left main. So we have to be aware of that length. And the positioning of the port balloon is important to place the balloon exactly at the carina. Also to understand the protrusion of some balloons beyond the marker. So we need to know the characteristics of the balloon also. So to place it exactly at the carina. So once we do that, we have to make sure we do a good dilatation, which helps to nicely expand the stent and also to oppose a stent into the side branch, which can be further optimized by kissing balloon. So why do we do a proximal optimization? It basically corrects the proximal malapposition, reduces the risk of abdominal wiring, and keeps the side branch ostium patent, which means easy to rewire. This is very important aspect of the port. And finally, one of the important aspects of port is to adapt the stent to the anatomy of the bifurcation, so that you have a good final geometry and flow dynamics, so that the stent gets adapted to the vessel. So to do this, to do a proximal optimization, when you have particularly when you have a tapering vessel, we need to understand the stent design characteristics. It's important to have a stent which can be expanded well proximally. So current generation stents, most of the current generation stents are capable of good expansion by, for example, all these stents like Expedition, Monix, Ultimaster, Biomatrix. Particularly, these are all open cell design with 2 connectors, which are more favorable for bifurcation lesions. So once we choose the size of the stent, do a proximal optimization, the next important phase is to recross. And it's important to try and recross through the distalmost strut.
Here is a different.
Whenever possible, particularly for a provisional stenting. So we try to cross a distal strut, as we understand that when we do a distal crossing, we get a better scaffold, better apposition of the metal, and you get a better side branch opening. So next important step after recrossing is a kissing balloon. Again, it's important to do a kissing balloon properly. So we need to understand that you have to use short non-compliant balloons. An example where you use of a compliant balloon, you can see that the stent is really not expanded well compared to use of NC balloon. And the sizing of the kissing balloon again is based on the distal diameters of both the distal main branch and the side branch. And when you have a very tight lesion in the side branch or complex stenting, it's ideal to do a very high pressure dilatation of the ostial side branch and then do a kissing balloon. So, and most often the kissing balloon, when you inflate, we have several ways of inflating. One, you can inflate the side branch first and keep it, go up to 12 atmospheres, bring it down to 4 atmospheres, then increase the main branch to 12 atmospheres, and then deflate both together. Particularly when you do a technique like tap, it's important to deflate both the balloons simultaneously. Another important aspect of kissing balloon is the duration. It is very important to maintain the duration of to more than 20 seconds. It is clearly shown in this study where if you do less than 20 seconds, definitely you have a lesser expansion, lesser cross-sectional area, and also more stent recoil. So it's more important to make sure you keep a good kissing balloon dilatation. The next step after kissing balloon dilatation is doing a final pot. The importance of doing final pot lies from this image where you can see if after kissing balloon, you have an elliptical deformation of the vessel. You can see in this OCT image where the ellipticity index is quite high, which can be corrected after a final pot, which becomes perfectly circular. So this will have a good flow and reduce the shear stress, proper flow of the blood vessel, reduce the risk of stent thrombosis or the risk of stent occlusion. So next step is when do we consider using 2 stents? Most of the bifurcations we want to use 1 stent and try and minimize the number of stents. But in some situations we need to consider 2 stents from the beginning, or sometimes to convert after from provisional to 2 stent technique. So mainly for true bifurcation where you have Medina 1-1-1 bifurcation, or when you have a large side branch, again it depends upon the territory of supply, large myocardial supply. Or if you have a side branch with a difficult access, so for example, it's highly angulated or calcified, then you need to think of starting with a side branch and using a 2 stent technique from the beginning. So basically the principles have to be very clear. We have to limit the number of stents as to minimum as possible, mainly 1 stent for every bifurcation possible. And it's important to ensure good apposition. Remember, under expansion is one of the powerful predictors of stent thrombosis. So we have to respect the anatomy of bifurcation and try to expand the stent very well. So when do we choose and what type of treatment for 2 stents? When we decide to do a 2 stent, again, we have several factors like looking at the disease distribution, the size of the vessel, the angle of bifurcation, and we decide basically if we have a proximal vessel which is undiseased and we have both the branches are diseased, then one can think of a V stent. If you have an angle which is more than 90 degree, one can use a T stenting or a tap technique. However, if you have a very less than 70 degree angle, one can use either a culotte or a DK crush. Depending, you can do either if you want to convert from provisional, you can do a culotte technique. But it's important to remember that as opposed to a provisional single stent technique, where kissing balloon may not be mandatory, you can just do a pot and then leave it with pot. But in a 2 stent technique, that kissing balloon is mandatory. It's important to finish finally with the kissing and then do a final pot. Remember that every time when you're performing a complex bifurcation, remember that always that when you put more number of stents, the risk of stent thrombosis is higher. As you can see here, you do complex strategy, it favors more stent thrombosis. And number of this is one of the meta-analysis from 9 random studies, as well as is a 5-year follow-up where you can see this where you have when you have a complex strategy with more than 1 stent, like a T stenting, you have a higher risk of stent thrombosis. So remember that whenever possible, for any bifurcation, reduce the number of stents. Try to do with a single stent. And the role of imaging, again, it's very useful, but it's not that it's mandatory to do, but it's quite useful both IOS and OCT. Particularly, it can clearly visualize the extent of disease, the type of the plaque, whether there is calcification, and particularly you have something called Here you have the distance between the carina and the outer lumen. This is called a spiky carina sign. So if you have a carina which is spiky, then the risk of side branch occlusion is much higher. So now there is a lot of interest in OCT to know where the wiring, whether we have wired the distal strut or the proximal strut. So again, we have to do a number of runs with OCT with more number of contrast if it is possible. If it's possible, then you can do this to see where exactly you're crossed. And finally, final assessment for stent expansion. Imaging really helps. Both IVUS and OCT will be very helpful to assess the stent expansion. When we have doubts on imaging, of course, physiology has a big role, and FFR can help to assess the side branch significance. And particularly, when you do a provisional, one can look at the side branch and decide to stop with just one stent. So let me now go to a few cases. I'm going to talk about only 3 techniques, more common techniques what we use. The provisional T, and that is the main technique. And then we have the 3 techniques, the tap technique and the culotte and the decay crush. So I'll show 4 cases and we'll go step by step. Provisional T stenting, as I already told you, it has got advantage of just single stent, and there is no risk of carinal shifting. You choose the size properly, as you can see here. After pre-dilatation, single stent from main to from the main branch alone. Then you cross. Then you do a pot. You cross and then do a kissing, which is not mandatory. You can do a kissing or leave only with pot. And final result is like this, where you have a good scaffolding of the side branch stent into the side branch ostium. So let us go to one of our case examples. Here we have a LAD diagonal bifurcation lesion. It's Medina 111. So when you look at the bifurcation, we know that it is a true bifurcation. The diagonal size is quite large compared to the distal LAD. It's a large territory, so it's very important. So one need to think that we have to protect the side branch at all costs and consider, make sure that we have a good flow of the diagonal end of the procedure. So we want to do provisional in this case and then decide to stent the diagonal if needed. So we in fact did an FFR to the diagonal and found that it was significant. But the major challenge here is the distal diameter of the main branch is hardly 2 millimeters, and you have a proximal diameter almost 3 millimeters. Again, the use of Finnett's law will help. If you look at this bifurcation, the distal diameter here it's 2 millimeter, the diagonal is 2.25 approximately, so 4.25. 4.25 into 2 is it is 8.5 divided by 3 is almost 2.7 or 2.8 proximal, nearly 3 millimeter proximal diameter. So we know the proximal diameter, and accordingly we know we should take a small stent like a 2.25 or 2 millimeter stent and use a pot with a 3 millimeter balloon. So that should be the plan. So we used a 2 into 22 millimeter resolute onyx. Again, you have to understand the expansion characteristics of the stent. We know that resolute onyx 2 millimeter can go up to 3.3. So we know that it can go even off label, it can even go more than that. So we did use a resolute onyx 2 millimeter stent and then did a pot with a 3 millimeter balloon. Followed by pot, we recrossed and did a kissing balloon with a 2.5 millimeter balloon in the LAD and a 2 millimeter balloon in the diagonal. And after kissing balloon, this is the final result. And we do a final pot again with a 3 millimeter NC balloon. So then we do a OCT to see the diagonal. It looks good, 0.89. So we don't want to do another stent in the diagonal. So we just leave with one stent. So the most important part is to look at the pot. You can see here the vessel diameter is quite, stent is very well opposed. And you can see the stent, the shape of the stent is very expanded proximally, and you can see the distally, and in the carina, as well as in the ostium or the diagonal, the stent is well scaffolded. So moving on to tap technique, it's just an extension of the provisional T. If you have a dissection in the side branch, or you decide to stent the side branch, or you intentionally decide to do 2 stent taps possible. So once you do a single stent in the main branch, just like how we did a provisional, after that you decide to do, you can open up the side branch and put in another stent and keep one more balloon in the main branch when you place the side branch stent. It's important to position the side branch stent exactly at the ostium, or just give a micro tap slightly protruding into the main branch to make sure you have a full coverage of the ostium. That's the whole idea. So once you keep the stent properly, then you inflate the stent and followed by that, you can pull the balloon in the main branch, and using the same stent balloon, the side branch, one can do a kissing balloon and get a good result. But you create a neocarina metal. Neocarina is made of metal, so it's important to make sure you have a good kissing balloon and simultaneous deflation. If you deflate one balloon, then the carina may shift towards the other side. So it's important to deflate both the balloons simultaneously. You have a carina which is kept central. So one of the pitfalls is you create a neocarina with a single layer of neocarina in the middle. So this is one of our patients where you have again a Medina 111 LED diagonal bifurcation. So we pre-dilate both the branches. First we pre-dilate, followed by stenting the. Followed by, after pre-dilatation, we stent the main branch. After main branch stenting, we recross and then do a kissing balloon. And once after that, we decide to do another stent with the tap. So you place a side branch stent and keep a balloon in the main branch distal to the stent, and position the side branch stent properly. Once we do exactly the marker just slightly into the LED, and once you do that, inflate the stent and then pull both balloons and perform a kissing balloon and simultaneously deflate. And this is quite a simple technique and have a good result. So it's quite a simple technique to do after provisional. Next is a culotte technique, culotte stenting. Again, this is again useful when you want to convert again from provisional. You can go to either tap or to a culotte. So culotte steps again, it's dilatation of both the branches and followed by stenting the most difficult branch first, usually the side branch. We stent them from the main branch to the side branch and then rewire, do the first pot, and then after the first pot you rewire and then put a balloon and another stent, and after placing another stent do second pot and then rewire and do the final kissing. After the final kissing, do again another pot. So this essentially has 3 pots to get a good result of culottes. We'll show an example. This is again a bifurcation involving the left main. So you have a lesion in the circumflex, almost a total LAD near to which is recent occlusion, and you have a proximal LAD lesion. So if you look at this lesion, we did a FFR to the circumflex, which was quite significant. So we have a significant disease in the proximal LAD, osteal circumflex, and the left main is large. So we decide here to do a 2-stent technique from the beginning, but the angle is less than 70 degrees, and also both the vessels are almost 3.5 millimeters, almost equal. So we planned a culotte technique. So here we do a first stent from left main to the circumflex, and followed by the first pot. So I think the pot is very important. Once you stent the first stent, you do a pot. After the first pot, you rewire, and then we dilate into the LAD. So this is the first pot, followed by a stent into the LAD, and after stenting the second pot, after the second pot, you rewire again and do the kissing. After the kissing, you do a final pot again after the kissing. So, and this is the final result. So again, it's important to do this properly, as I told you, to do the proper techniques with the pot and final kissing balloon. So finally, the DK crush. Again, this is one technique when you decide to do a planned 2-stent technique from the beginning. This is a very elegant technique, but again, you have to go with step by step. So first here, you perform the side branch after pre-dilatation of both branches. You do a side branch stenting with the balloon in the main branch, and you crush the side branch stent, followed by recrossing. And before you take you do a kissing balloon. After the side branch stenting, you remove the wire, do a nice kissing. After that, you put the main branch stent and recross again. The only exception here is when you want to recross, you can go with either the middle strut or the proximal strut, as opposed to the distal strut when we use the provisional technique. So once you recross, then you do again a second kissing balloon, followed by again a pot. So this is the final result. So I'll give you an example. This is an LAD diagonal bifurcation lesion, again a 111 lesion. So in this case, first we decide to whether we use a single stent technique or a 2-stent technique. But after doing imaging, we find the LAD diameter. The diameter is a 3 millimeters vessel. LAD is a 3 millimeter vessel, and diagonal is a 2.5 millimeter vessel, have a huge block burden. So we decided to do a two-stent technique. So we do IVS to the diagonal as well and see a huge block burden, a large diagonal. So that is the reason we decide to do a two-stent technique. So as you can see here, the LAD is large and there's a wide angle. So we decide to do a DK crush. So what we did was we put a stent in the diagonal, keep a balloon in the main vessel. After stenting the diagonal, we crush the stent. And once you crush the stent, then you remove the wires, remove the diagonal wire, and you put in do a kissing balloon. First kissing balloon is the first kissing balloon. This is the result after first kissing. Then put a main branch stent, and then you rewire and do a second kissing balloon. And this is the final result. And we do imaging. Imaging is encouraged whenever possible. And we have a good result by IVS and angiographically. So we learned about the most common techniques. I'm not going to elaborate on many other smart techniques, V-stenting and all that. But finally, I would like to mention a little bit about the dedicated bifurcation stent. Number of dedicated bifurcation stents are available, and we are also a part of some trials in some of these stents. But again, we need to have a very ideal stent, which is quite easy to use and very safe to reduce the procedural time, and mainly to have a good side branch access, and so that we can treat all bifurcations with a single type of stent, which is still still don't have such a stent. So to conclude, I would like to give these messages. Provisional T-stenting is a default strategy for simple bifurcation lesions with a low rate of side branch stenting, and there is no harm of doing a final kissing balloon, but proximal optimization is mandatory. Complex stenting should be a default strategy in complex bifurcation lesions, and when using two stents, it's mandatory to do a kissing balloon finally. There is no gold standard technique, but Culotte and DK crush seem to give good results. All bifurcation stenting techniques require step-by-step approach, and each steps need to be respected to provide optimal outcome. Thank you.
Wow, that was a fantastic overview on a very, very difficult topic. Thank you very much. So really appreciate it. I think you really talked about the various key techniques that we use. When do we do provisional? When do we do a dedicated two-stent strategy? How to use imaging? When to use FFR? Hey guys, I know we have a fairly tight schedule, so if there are questions that pop up that you guys want to address, just individually or even on the chat forum on the site, please feel free. If something needs to be discussed, then just go ahead. So I'm not going to talk too much because I feel like I am. There's one question. When do you do FFR and side branch, before or after main branch stenting? So I'd request one of the panelists, you guys, whoever wants to, can take a shot at it. Maybe Juan or Dr. Sridhar, anybody. Guys, is everyone unmuted? Can we unmute everyone, please, for the discussion?
FFR, particularly in true bifurcations, doesn't have any significant role. But if it is not true bifurcation, and there is no significant side branch and main branch stenosis, that time it's reliable. And the thing is, usually if you take definition criteria also, there is a one way to decide whether it's simple or complex, where DK crush has shown much better pattern, a much better MACE rate in even in provisional stenting versus DK crush. But as per the ESC guidelines, other guidelines, provisional stenting is the first choice because based upon the meta-analysis. Side branch FFR, suppose if the ambiguous lesion or if you like a non-LM bifurcation, if it is less than 90%, do the FFR and rule up. More than 90% not needed as per the definition criteria. If it is LM bifurcation, more than 70% stenosis side branch, then straight away you can go ahead. But if less than 70%, you are not very sure whether it's significant or not, that time you want better to do the FFR. And post-stenting also, after provisional stenting, because the carina shift, there is a side branch pinch. there is a study. They have studied FFR in side branch pinching in 50 patients, out of which when they compared angio versus FFR, and FFR was positive in only 20%. They assessed when the angiographic evidence of more than 50% stenosis, they evaluated angio versus FFR. But the angio-wise, it may be significant, but FFR-wise, it's not significant. That's the reason, if needed, because if you put additional stent, you are going to increase the MACE rate. The FFR is going to reduce the MACE rate by minimizing the number of stents. That's the most important point. So only if needed, you put additional stent. If non-LM bifurcation more than 90%, definitely you can. If it is a LM bifurcation more than 70%, 50 to 70%, you are not very sure, do the FFR. If it is physiologically significant, go with side branch stenting. So provisional stenting is the first strategy. Suppose real true bifurcation, straight away you can. Even recent guidelines, whenever you are going ahead with any two stent techniques, preferable to go ahead with the DK crush because the supportive data is more in favor of that. But at the same time, they also mentioned very clearly, suppose the operator is not familiar, whoever is familiar with whatever technique, they can implement that technique. That is the strategy.
Actually, Arun, basically the only one point to be stressed here, basically because of the pseudo lesions. You may you may think that there is an angiographically significant lesion, but it will not be significant in a provisional stenting. In that situation, an FFR will give a guidance whether to stent or not. That's the only point to be stressed here.
Thank you, Dr. Sridhar and Dr. Pratap. Unfortunately, Dr. Ashok sir does have another commitment, so I'm going to request that he, be involved in this discussion. Shripal, sorry, I'm going to delay your talk a little bit so that we can kind of hear from Dr. Seth.
So Arun, what had happened was that I got disconnected, so I've reconnected again. So I didn't hear it, but that was a great talk. I just have 2 or 3 comments to make. One was regarding the final pot. More and more we're getting away from the fact that we don't need to come near the carina at all. The final pot needs to be well away from the carina. That's the editorial I've written up for the CCI, which will appear perhaps next month. That's to say on top of the pot. And that's primarily because once you've done the first pot and you spread that enough, just proximal to the carina, anything you start going near doesn't have any advantages, but can only impinge on the side branch and do away with whatever you're doing. So come well back, come into the main vessel, come well away from the carina. In fact, it should just be in the main vessel, and that's about it. Second thing is this kissing balloon. While Singletubelu demonstrated the kissing balloon inflation with the balloons well into the main branch, actually what really works best is if you just have it in the polygon itself, so that you actually have distal, then you don't distort the proximal at all. And you may not need to do a pot even. So it's like you do for the left main, short balloons just protruding a couple of millimeters into the main vessel to just finish in the polygon rather than have them well back. And I think that the third and only point I'd like to make is, even in culottes, that's probably the only condition in which you do proximal crossing. But we must remember that whenever we do proximal crossing, while in a distal crossing not in a culotte, in a crush.
DK crush.
In a DK crush. That's the only point where we do a proximal crossing because we're worried about going distally and then lifting the stent off. But the point becomes that you create larger metallic neocarinas the more proximal you go. So it is, the way I do it is always that in the second time it's the mid-cross so that you separate out the metal on either side rather than have too much metallic carina. So the closer we are, the farther we are away from the carina, the greater metallic neocarinas that we create, and that should always remain in our mind.
Sir, good evening, sir. Pratap. Sir.
Hi, Pratap. Good to see you.
Sir, actually, there is one point, actually, you clearly told there are some lot of balloons have an overhanging balloon.
Correct.
So if you are just reaching up to the carinal tip, then you may extend to the main vessel. That is actually a very important point to be stressed.
And don't come near the carina at all. It's not needed in the final pot.
Yeah,
and the final pot can be done with a compliant balloon. It doesn't necessarily need to be done with a non-compliant.
Okay.
And the balloon characteristics have to be known because some of the balloons protrude a lot from the marker, so we have to know that also.
So the first pot is very essential to be near the carina because that's when you open up the cells, but the second pot doesn't need that at all.
Absolutely.
Dr. Seth, thank you so much for sharing those, your wealth of wisdom. Really appreciate it. I don't know when you exactly have to leave.
It's on India Today channel at 8 o'clock, sir.
So we won't have you for too much longer.
Yes,
but you're going to miss
I'll listen to
Shripal's talk on left main.
I know. I'm going to listen to most of it till they want me on the.
Sure. So let me not hold you guys back. We'll save some of the discussion for the end. Any other questions, etc., we'll just save it for the end. So I don't want to delay Shripal either. So Dr. Sid, thank you so much. In case we do lose
wonderful. I mean, you've got a great panel. I just miss sitting with you.
Are you able to hear me? Very good evening, sir. Nice to see you.
Nice to see you, Kasturi. Nice to see you.
So I'd like to welcome Dr.
see you.
Shripal. Yeah.
Thanks, Arun. I hope you can hear me. Thank you for having me on. Okay, great. So I'm going to share my slides, and it's great to see the amazing faculty. And I think it was a wonderful discussion. Kind of leads into my talk, and it makes my talk much easier. This is approach to left main disease. And I think this is also more important given the controversy that's been going around, especially on social media about left main disease and our approaches to these patients. So what I want to do is start with the case, and we'll also discuss some data in between, some techniques, and so forth. So this is a patient that I did a few months ago. I mean, this was pre-COVID, so definitely not in the last 3 months. So it's around 6 months. So 72-year-old female. She came in with the exertional angina for 3 months. Interesting history in the sense that she has a history of anxiety, IBS, and ex-smoker, but she was very symptomatic, chest tightness and dyspnea and exertion after walking less than 1 block. Initially, she was minimizing her symptoms, but she reached a point that she was very symptomatic. She underwent a stress echo, treadmill stress echo. She had chest pain during the treadmill. Interestingly, the echo only showed apical ischemia, but there was also a TID, so the referral was obviously concerned with this particular patient, and she referred this patient for coronary angiography. So this is an outpatient coming in, so we did a right radial approach. This is a Jackie catheter, so this is the first picture, and as we can see here, this patient has a critical distal left main bifurcation. And what we can also see, I'm not sure how well it projects there, but you see that the left main is heavily calcified LAD, and also the circumflex artery. And you can see on this caudal view, let's see if it's obvious, but you can see here, this is a true bifurcation 1-1-1 in the sense that the ostial LAD and the ostial circumflex are also critically stenosed. And you see that all 3 limbs are have significant calcification. So this was our RCA. The RCA does have some mild to moderate stuff in the mid, and nothing significant. So this is where we are in terms of her. So she came in the morning for this procedure, and here we are in terms of her summary. CCS class 3 angina. Although the last couple of days she's been saying she can hardly walk 1 or 2 steps before she starts feeling angina. Positive stress test, but it just goes to show that sometimes you can have underestimation. It was just called as apical ischemia, although there was some TID. Normal EF, but severe calcification of left main ostial LAD and ostial circ, and this is a true bifurcation in the sense that it's a Medina 1-1-1. So the question is, how should we manage this patient? So we'll come back to this patient. I just want to show some data, and I think part of the confusion is also whatever has been going on around the Excel controversy. So I think it's, I thought we'll take a couple of minutes to discuss. So in terms of coronary artery disease, of course, I mean, this patient is stable ischemic heart disease, not an acute coronary syndrome. So options are optimal medical therapy, PCI versus Cabbage, but how do we apply this to patient with significant left main disease? Of course, it's again important to recognize the mechanism of action of all of these different modalities. Many are not separate and many are complementary. Optimal medical therapy in terms of the target. It targets both significant and non-significant lesions. So in fact, of course, this crowd is very familiar, but it's important to emphasize, regardless of what we do, medical therapy is key for patients, whether patients undergo just medical therapy or PCI or for Cabbage, because there are a ton of non-significant lesion, and the main approach for that patient is optimal medical therapy. Of course, we have a ton of medications, and that leads to the concern of polypharmacy, and that's where you see this pill man on this picture. What about bypass surgery? The advantage of bypass is we are bypassing the first 50 millimeter segment of the coronary artery. So it targets significant stenosis, the 70% or greater stenosis, but also some non-significant lesions in the first 50 millimeter segment of the coronary tree. But in fact, I've debated a number of surgeons, and the surgeons will say that the lima will outsurvive the patients. But jokes apart, it does have benefit in the sense that it affords protection against plaque rupture coming from the non-significant lesion in the first 50 millimeter segment that is bypassed. PCI it only targets significant lesions. So if a patient says they're not going to take any medical therapy at all, PCI in patients with diffuse disease is more like patch treating a systemic condition. So it's important to recognize this kind of paradigm of what each modality treats and what's the best approach for your patient. Of course, none of these are without trade-offs, OMT, medication-related side effects. Cabbage is invasive. PCI minimally invasive, but still invasive. So there are trade-offs to consider. And so first, if you look at patients with left main disease, what is the data for revascularization versus medical therapy? And if you dig back to the data on randomized trials, these are Cabbage versus no Cabbage trials done in the 1980s. And left main was a small subgroup, but Salim Yusuf's meta-analysis shows that there is significant benefit of revascularization with the Cabbage when compared to no Cabbage, hardly any medical therapy back then. And in fact, the left main subgroup had the biggest benefit. And so the extension of survival by close to 20 months at 10 years follow-up. But the key thing I want to emphasize is look at the number of patients where we base our evidence on. It's 150 patients. And of course, given such significant benefit, it's very difficult to do trials on these patients because, it's the left main. And of course, when we did the ischemia trial, we also excluded patients with left main disease given such data. But within that data, it's interesting to also note that the severity of left main may have an impact on the benefit of revascularization. Here is the VA cooperative trial dividing patients with left main to greater than 75% versus 50 to 75%. And you see Cabbage, the absolute benefit is greater if the percentage stenosis is greater than 75. The absolute benefit is less if it is 50 to 75. But of course, the interaction p-value is negative, so one may debate that the benefit is equal in the subgroups, but the more severe the left main stenosis, greater is your benefit from revascularization. So clearly, at least back in the day trials, medical therapy is not a good option for patients with left main disease, medical therapy alone. So what about PCI versus Cabbage? And this has been matter of debate in the last 6 months to 9 months. If you look at the 2018 ESC myocardial revascularization guidelines, so if you have a patient with left main disease and you subcategorize them based on their complexity as low, intermediate, and high syntax score, ESC guidelines would give a class 1 for both PCI and Cabbage if you have low syntax score, class 2A for PCI if it is intermediate syntax score, and class 3 if it is a high syntax score. And of course, it's class 1 for Cabbage across any of the syntax subcategory. So this looks great. And of course, this is also endorsed by the European Association for Cardiovascular Cardiothoracic Surgery. So a pretty heart team-based approach recommendation for left main disease, up until the point that we saw this headlines that European Association of CT Surgery pulls out of the left main guidelines based off of this report from the BBC alleging that Excel trial, there was some cover-ups and the definitions of MIs were concealed. The rates of MIs based on revised definition will be higher with PCI than when compared to Cabbage. So just to look at the Excel trial at 5 years, this was published late last year, looking at 5-year data between PCI and Cabbage. And what we can see here, the curves do cross at around 36 months of follow-up. And at 5 years, you see that there is no statistically significant difference, but you see that numerically there is small benefit of Cabbage when compared to PCI. But of course, there is a time treatment interaction, which is extremely important to recognize and also useful to when we talk to our patients, in the sense that if you look at this composite death MI or stroke, upfront, there is significant higher risk of Cabbage. So more death MI stroke with Cabbage when compared to PCI. Between 1 month and 12 months, no difference in outcomes. And after 12 months, you see the curves separate, favoring Cabbage at around that time point. So this relationship is important as we, consent our patients for procedures. I'll skip this in the interest of time, but of course, the Excel trial investigators, including Greg Stone, came up with their response to all of the data suppression claims and all of the claims that have been leveled against them. And this continued to create a lot of controversy here, in the sense that the Society for Cardiovascular Angiography and Intervention had to come out with their own statement. This was an email which was sent out to all of the interventional cardiologists in this country and around the world, that they disagree with the EACTS regarding the Excel trial. I posted this back in the day. So I said the BBC Excel issue is being made into a conspiracy theory. Regardless of the definition of procedural MI, the totality of data does not support mortality difference between PCI and Cabbage. So this was, I think, around 6 to 8 months ago. And of course, a lot of people, weighed in on it, 33,000 impressions within a matter of 24, 48 hours on this. So, just to look through it in much more detail, if you look at the 5-year outcomes, clearly Excel, this is all-cause mortality. When you compare Cabbage and PCI, 9.9% mortality with Cabbage, 13% with PCI. The difference is statistically significant, 38% increased mortality with PCI when compared to Cabbage. And, the surgeons looked at it and say, okay, the curves are separating and it's likely to continue to separate. But interestingly, this is at odds with many other trials. If you look at Noble, which was published around the same time frame, and if you look at the 5-year data, no difference between PCI and Cabbage in terms of survival. And of course, PCI and Cabbage, there are differences. The short-term outcomes favor PCI. And you can see with Cabbage, there is a significant increase in a number of endpoints, increase in stroke, MI, bleeding, reinfarction, etc., around the time of the procedure. So where do we stand in terms of PCI Cabbage for left main disease? So this is data which we published a couple of weeks ago. This is a meta-analysis of randomized trials, 4 randomized trials, over 4,000 patients left main disease. And all of these trials reported 5+ years of outcomes. And for mortality, which has been the contention, you see that when you combine all trials, there is actually no difference in mortality. I also want to point out, if you look at 3 trials versus Excel, Excel seems to be an outlier. All other trials seems to show that there is no difference. And if you include Excel, again, no difference in survival between PCI and Cabbage. One of the widely discussed topic has been this James Brophy Bayesian interpretation of the Excel trial. But I must say, his analysis is exactly same as ours. So if any of you have lingering doubts, I want to just show this figure from their analysis. So if you look at the Bayesian way of looking at it, this shows the prior information from Syntax, Noble, and Pre-Combat. The blue lines are from Excel. So if you look at these two mountains, so you can clearly see that they're not same. In other words, Excel, for whatever reason, is an outlier when compared to all other trials. When you combine these two, you get your posterior, and the posterior probability of, if you look at a 1% mortality benefit at 5 years with Cabbage, which is a small 0.2% benefit per year, it's only 47%. And I think this is critically important to tell our patients. If you're looking at this tiny benefit, the probability is only 47%. So what is 47%? It's flip of a coin. So in other words, in my opinion, based on all of the totality of the data, there is actually no difference between in survival between PCI and Cabbage. So we also published this looking at other endpoints. So if you look at cardiovascular death, myocardial infarction, stroke, again, no difference between PCI and Cabbage. The only difference between PCI and Cabbage is, again, repeat revascularization. So significantly higher repeat revascularization with PCI when compared to Cabbage. So just to summarize, if you look at all of the data, no difference in mortality, only difference in repeat revasc between PCI and Cabbage. So in appropriate patients, either PCI or Cabbage are suitable options. So let's go to our patient. So in this particular patient, we did calculate a syntax score. She's still on the table. The syntax score is 15. In fact, it's a low syntax score. But given the fact that she had calcification on both limbs and she needed rotational atherectomy, we did offer her the option of, do you want to come off of the table, off sedation? We can talk to you more in detail. But she was very adamant that nothing is going to change her mind. She does not want bypass surgery. So we said, okay, let's go ahead with PCI. So we're still 6 French radial. So we had a EBU 35 6 French guide. And the first thing we did was, let's see if this plays. We did IVUS from the LAD into the left main. The IVUS was more to say, since this is, both limbs needed rotational atherectomy, I wanted to better define the ostium of the LAD and also ostium of the circ. Here, what we see here is, this is the LAD, and you can see a 180-degree arc of circle. So we are now coming into the left main. So now here you see 360 degrees, but this is the distal left main. This is the proximal left main, looks okay. So a couple of things that we can take away from this IVUS is that there is a 180-degree arc of circle in the LAD, but the ostium of the LAD is not critically narrowed. It's severe, but it's not critically narrowed. So in other words, my probability of this LAD going down is actually not that high. And of course, distal left main 360 degrees. So you see all of these echo shadowing. So we can't see beyond this. So significant calcification. We did the same thing with the circumflex and severe calcification of the circumflex into the left main. So what we did next was, I don't have the pictures of the circumflex, but anyway, so we decided based on the fact that the left LAD ostium is not that critically stenosed, I wasn't too concerned about using, so there are a couple of techniques you can use. You can either use 2 guides and cover, if you're really worried that rotational atherectomy of one limb will close the other limb, you can use 2 guides or 1 guide with covering one of the wires with a microcatheter, etc. But here we went in with a single 6 French technique. So we wired the circumflex. We did a 1.5 per rotational atherectomy into the circumflex. We took a look at it. Now there was no issues with the ostium of the circumflex. We now took the rota burr back. We wired into the LAD. Now we are doing the rotational atherectomy into the left main, into the LAD. And of course, since it was only a 1.5 burr, we usually do a 1-to-1 sizing before putting in any stent in such heavily calcified arteries. So now we have both the wires after the rotational atherectomy, one into the LAD, one into the circumflex. We are dilating this with a 3012 NC balloon. So we see that it nicely expands. We did the same thing with the LAD, so we can see that it nicely expands, so we don't have to upsize any of our burrs. So we are now putting in one of our first stent. I'm glad that there was that talk on bifurcation, the excellent talk. So usually what I tend to use for left main disease is a DK crush technique. For years, I used to call it Bangalore modification of the DK crush technique. I'll tell you, briefly describe the small modification I do. So here what we see is you have a blocking balloon in the LAD. At this angle, you see that the left main bifurcation is actually here. So I think it kind of, the blocking balloon also helps us better define that. So now we have a 3.5/16 Promus stent. We're using the blocking balloon there, inflating this Promus stent. The next step which I do is slightly different than traditional DK crush in the sense that we now pull this stent balloon slightly back, a couple of millimeters, 5 millimeters back. And then we inflate both of these balloons to form a kiss. So we'll do a kissing balloon inflation here before I actually crush it. As I was saying, I used to call this the Bangalore modification of the DK crush, only to realize recently that there is a term for it. So this is called the DK nano crush technique. But anyway, so we pull this back, kiss it. Now I take the wire out, crush it, and now we're placing a stent here, 35 by 28 Promus. So once we are done, we do a pot. So this is a 4/12 pot. We then rewire and taking a 3/5 and the 3/5 NC kiss and repot. So I agree with Dr. Seth was saying you gave such amazing tips. I think all those are critically important for the treatment of left main disease. So the repot, you don't have to be exactly at the carina. The key is to be within the main stem. And so these were the final results. Of course, I was very well opposed for both the limbs, and this is what we saw. And here again, a different view, you can see that it's nicely expanded. And of course, just to summarize for this particular patient, we did rotational atherectomy of both branches. And of course, one of the concern is, can you actually close off the other branch when you're doing rotational atherectomy across it? And we have done a number of these procedures, and especially if you plan it with IVUS and better define the ostium of the other branch where you're not doing rotational atherectomy up front, it can help predict whether the other branch will go down and what we need to do. I mean, in our experience, it's very rare for the other branch to actually go down. So we did IVUS pre and post, and this is called a DK nano crush, and you can see, I mean, the full technique is DK nano crush pot repot technique. So we're doing pot a couple of times. In fact, this patient came in that morning and was discharged the same day with aspirin and prasugrel. So you can imagine, so the option for her was Cabbage. She would have waited a couple of days for the antiplatelet to wear off, then would have had a bypass surgery, waited a couple more days, long recovery time. But this patient came in that morning with severe chest pain, had PCI, discharged home the same day, and she's back to being fully functional in terms of what she does. Just to some more data in terms of intracoronary diagnostic techniques, it's a 2A recommendation for guidelines to assess severity and optimize treatment of unpredicted left main disease. So in fact, left main is one of those lesions that it's almost mandatory to do intravascular imaging for all of these patients. So, and of course, I mean, IVUS versus OCT we can discuss, but most of the cases we do use IVUS just because it's so big, and OCT can have issues with complete opacification and given the size of the left main disease. And in terms of the techniques, I have almost fully, if it is a true left main bifurcation lesion, fully converted to DK crush. It's only occasional patients where maybe a culotte technique, but most of it is 99% of it is actually DK crush. And of course, this is driven by data. This is the DK crush 5 trial. Patient with true distal left main bifurcation randomized to DK crush versus provisional stent, and DK crush was superior. Reduction in target vessel failure, reduction also in definite probable stent thrombosis, use a DK crush technique. And of course, there are a number of computational flow loop models and OCT-based analysis which shows that DK crush optimizes your carina, and that's likely the reason why you get superior outcomes. If you have not looked at this article actually came out a week ago. Look at all bifurcation lesion stent techniques. It's a network meta-analysis of randomized trials looking at all of the things that were discussed in the prior talk, TAP, provisional, DK crush, culotte, and crush. And as you can see here, 21 trials, 5,700 patients. And again, not much difference within other techniques when compared to provisional. The only one technique that stands out is the DK crush technique. So more and more, we seem to be getting robust data that DK crush may be the way to go if you have a true bifurcation technique. So the other thing that comes up routinely is, should we be using support for your left main patients? And I think the audience we're speaking to, I think, is great. I mean, I don't think people there use a lot of mechanical support, but in other parts of the world, there seems to be a knee-jerk reflex of using a lot of support. I mean, we have done over 50-20 left mains in the last 6 to 9 months, and I can tell you that it's only been 1 or 2 patients where we have used support. So when do I use mechanical circulatory support for such patients? For example, the last case we did, it was 2-vessel rhoda. We didn't use support, and the patient went home the same day. So I would say use of support is mainly driven by hemodynamics and not necessarily the lesion. So if the patient comes in with acute coronary syndromes, is shocky, has narrow pulse pressure, hemodynamically labile, those are the patients we consider support. So I just want to show this patient, which we did a few weeks ago. 63-year-old male came in with shortness of breath. This was in the middle of a COVID pandemic, and of course, just like anything else, I mean, there was delay in care. People thought he may have COVID. He was isolated. His troponin went up to 150. He was in anuric renal failure. It was started on dialysis, and by the time we get to know the patient, it was already a couple of days into his MI. But on the day of his cath, we looked at his lactate. His lactate was elevated to 5. But anyway, these were his diagnostic caths. So as we see here, I mean, this is a 5 French catheter, and you can see the right is a kind of a small, diffusely diseased 90% lesion here. There is a near total occlusion there, TIMI2 flow here. And of course, I'm not sure how much it projects well, but this right is heavily calcified. And this is his left system. Again, he has a CT of his large OM. And of course, there is a heavily calcified left main. This may not project as well, but and you can see that LAD is also not a pretty big vessel. And here you may see some more of that left main. So there is some ostial left main, some catheter dampening. There is some distal left main, some proximal LAD, and then also some severe stenosis of his LAD here just below the bifurcation, severe stenosis of his mid LAD. So just to summarize for this particular patient, is post-MI, this was day 3, his lactate was elevated, so anuric renal failure, severe triple vessel disease, left main disease. If you calculate his syntax score, and of course, I mean, these are small caliber vessels, 5 French catheter, and you can see the distal LAD. Syntax score of 53, is echo EF was 25 to 30%, his index in the cath lab was 1.9%, 1.9. So in this case, we started him on some pharmacological, he started him on inotropes. We remeasured his index in the cath lab. It was improving, which took him off the table more to see if the surgeons would be interested in him. Interestingly, the surgeons waited on him for a long time, but it felt like a long time. So it was 8 or 9 days later, and they eventually turned him down, more so because he was intubated, his RV was dilated, they were not too keen on him. So we brought him back. At this time, he's still on dobutamine, no mechanical circulatory support in the CCU, but labile hemodynamics. So we brought him back to the cath lab. So we did a single access technique. So right femoral approach, ultrasound and micropuncture guided access. So we did a single access technique for impella placement. So 2 pre-closes. So we passed this impeller sheath in, and once the impeller sheath in is in place, you either puncture at the 10 o'clock or the 2 o'clock position and place your sheath. So we put in a 6 French destination Terumo sheath, and so it's just one single access. So we are not only doing mechanical circulatory support, but we're also doing rest of the procedure through just that single access. So in this case, the RCA, the distal lead was occluded. So we used an antegrade wire escalation technique, Turnpike LP and Fielder XT. And we swapped that to a rhoda wire. We rhodaed this with the 1.5 burr. And so, and again, I think this is an interesting case. And of course, we can also discuss, which artery should we go after first? I mean, we decided here, we can come back to it at the discussion, that, we start with the right first and then only go after the left. And, after dilatation, stenting, you can see the final results of the RCA. So a pretty good result, TIMI3 flow looks great. So we then switch to the left system. So here again, I mean, we have a EBU 375 photo guide with side holes, so significant catheter dampening. So for this circumflex CTO, we did an antivagated wire escalation with LP and a pilot 200. We were able to open that CTO, and this was the CTO post results after stenting. And finally, we decided to go after that LAD left main. So here the wiring was not a problem, swapped it to a Rhoda wire. We are now doing a rotational atherectomy with the 1.5 burr. And interestingly, what happened next was we could see on the Impella console that his pulse pressure, which was pretty decent, now becomes almost flatline. I mean, of course, his blood pressure was still stable, but he became solely dependent on Impella. And of course, I mean, prior to this, we had IVUS this LAD left main, and we had seen that the distal part of the LAD, mid to distal, I mean, well, it's almost hugging the catheter. It's like 2 millimeters. It's full of atherosclerosis. There is hardly any flow in that distal. It's just a small, diffusely diseased vessel. But soon after this, we realized that his pulse pressure was narrow, but his blood pressure was okay just because of the Impella. But it was almost a flat line. And then once we took a look, it looked like the mid LAD was occluded, likely from some of the debris that went in. But we were able to balloon it, wire it, and now we can see. So we did a LAD into left main, did a part here with the 4.0, then a 4.5, finally did an IVUS, and these were the final results. And at the end of the procedure, so again, this is single access technique, mechanical support, MCS supported multivessel PCI, rotational atherectomy, IVUS pre and post. And of course, at the end of it, we were able to remove the Impella at the end of the procedure. It was pre-closed, and we were able to take it out, and we did pretty well. Interestingly, the brief duration of time where there wasn't flow in the LAD, interestingly, made some lactate, which cleared off very quickly in the next couple of hours. And the reason the sequence is important is, I feel that if I had done the same thing going the opposite way, if I had started with the LAD and the LAD had closed, given the fact that he had a CTO of his circ and a CTO of his RCA, I think he'd have been a lot more unstable. The fact that we had opened up all of his other vessels made the LAD left main, the ischemia in that territory more bearable in terms of hemodynamics. So just to summarize approach to left main disease, of course, I mean, first of all, it's important to recognize the data we have. Data based on 150 patients would suggest a survival advantage of Cabbage over medical therapy in the trials done in the 80s. So, so it's important at least to bear this in the back of our minds that it's not a robust data, it's 150 patients, but this is what we have and this is what it is. So most of us, if it is a severe left main, I mean, maybe if it is a left main of 50, 60% and the patient is hesitant for any form of revascularization, medical therapy is not an unreasonable option, but in this day and age, for most left main disease, we do revascularize. It's important to recognize this PCI is a reasonable option in patients with low complexity disease, low to intermediate syntax score. And multiple set of data suggest that DK crush is preferable in those with true left main bifurcation disease. And critically important, I mean, whatever your technique is, it's important to optimize. IVUS is important to optimize your results, specifically for left main, because left main tends to be big. It's easier to underestimate the size. Malposition is going to be a big issue, and critically important to see IVUS these lesions. Thank you for your attention.
Shripal, fantastic talk again. Thank you so much. Guys, in the interest of time, I know that was an excellent overview of data, controversies, practical applications in a case, imaging importance, and some fantastic cases. So I'm going to request that we move on to Dr. Kwan Lee and then kind of save the discussion for later. just so that we can, and I believe he has a TAVR coming up, so we better not delay him too much.
Yes, sorry. Hello, can you hear me? Did you all just hear what I just said? Yep. So once again, sorry, thank you, Arun, for the honor of and privilege of being invited to participate in this conference. We're going to take a step back here from Dr. Bangalore's amazing, highly complex case and address some of the more basic aspects of day-to-day practice. Because, these, even though these things are small, they should not be overlooked, and excellent technique obviously results in excellent outcomes. So my topic today is distortions in recording FFR, the common pitfalls in FFR management. So at this point, I think most of us who utilize FFR on a daily basis are well familiar with the results of the landmark FAME trials, as well as the cutoff points of functional significance that we use to decide on whether we intervene on lesions or not. A primary thing to remember is that these thresholds we tend to use dichotomously, as in we just decide based on a firm borderline whether we intervene or we do not intervene, even though the data actually suggests that it's a continuum of risk. Because of this dichotomy, it's very, very important that we get accurate measurements, because good decisions cannot be made without accurate measurements. So even though some of the concepts that we're about to present here are very basic, we must pay attention and remember to adhere to good technique. The overview of today's talk, we'll start with the common measurement issues, both technical and physiological. Then we will touch base slightly on the physiological causes of the measurement issues. We'll review the overall false positive and false negative causes of FFR measurements. And then we'll pull it together by looking specifically at the FFR and intermediate left main disease, because it nicely synthesizes many of the issues that we'll discuss. First of all, we should always pay attention when we are initially calibrating our FFR. All lines should be flushed with saline, and the transducer height must be carefully set to 0. This nice slide from Dr. Toff's review article actually shows very nicely the effect of setting the transducer too high. If you accidentally set your transducer too high, your FFR will be falsely elevated because your PA will fall. And if you set your transducer too low, your FFR will be falsely depressed because your pressure is going to be higher than your PA is going to be higher than it's supposed to be. Don't forget, and we've actually seen this happen during some major live case transmissions, the effect of leaving the introducer in during measurement. If you accidentally leave your introducer in, the FFR will be falsely higher and therefore falsely negative, because the pressure in the PA will bleed out into the introducer and slightly be lower than and therefore your ratio of PD over PA will change. All pressure sensors are susceptible to drift. Drifts should be obviously absent or minimal for optimal measurement. Remember to check for drift immediately after measurement. Pull back the wire to the guide starting point and make sure the ratio of pressures continuously to be 1.0. The acceptable range is about plus minus 0.02 on either side. So if it's 1.02 or 0.98, that is acceptable. If drift is present, you have to repeat the measurement. This is a slide showing an example of what might hint at the presence of drift. If you look at the pressure tracings and they are of identical morphology, that can cause you to consider drift. Clearly, if a lesion is significant, the PD will change and look more ventricular, and therefore with different morphology, and that will give you a hint that you have actually a correct measurement. It is very important to achieve hyperemia, and the entire field of FFR is based on the construct that you have achieved maximal hyperemia. Therefore, if measurements are made without full hyperemia, the FFR will be falsely elevated, i.e. falsely negative. And several causes of the false idea that you have achieved full hyperemia are, first of all, insufficient hyperemic agent. If you are doing intracoronary boluses, you may end up choosing a bolus dose that is too low. If you draw blood back into the syringe before injecting the IC bolus and leave it for too long, adenosine is actually broken down by red blood cells, and therefore the effect of the adenosine will be diminished. If you're doing a peripheral infusion, if your IV is too small or placed too distally during a peripheral infusion, the full effect of adenosine will not be apparent. Many of us forget this, and in nuclear stress testing, we don't tolerate it. So it's interesting that as a pre-CAF checklist, I've seen in many labs, the failure to ask the patient whether they have consumed caffeine recently prior to the procedure, or if the patient is on theophylline-like medications, because those will suppress and compete with the effects of adenosine and therefore result in insufficient hyperemia. Once again, going back to pressure tracings, the signs that indicate the presence of hyperemia include a 15% change in mean arterial pressure, the sensation of having adenosine infusions, as well as ventricularization of the distal pressure tracing. And here is what you should expect to see on a prolonged run of FFR with regards to the drop in and the timing during a intracoronary bolus. You do have to recall that there is an effect on the size of myocardial territory supplied when you are evaluating a lesion. This diagram here demonstrates for an equivalent lesion on both sides, the larger the perfusion area will result in a larger physiological significance and therefore a lower FFR compared to a small perfusion area. Given the a set size of perfusion territory, if there is scar tissue, a similar issue will be seen. And therefore, even though you may have a large territory of perfusion, you may get a falsely elevated, or not falsely, but truly elevated FFR if there is significant scar tissue in the territory subtended. These issues are nicely brought to a head by the demonstration here of the effect of Cto and collaterals on FFR. Here you see a proximal LAD lesion and a RCA CTO, and pre-PCI, the LAD has an FFR of 0.74, while after the CTO is revascularized, the FFR rises into the non-significant range. When you are performing physiological measurements, it's very important to understand the effect of your guide size, as the larger guides will obstruct the coronary artery to a greater degree and therefore affect your FFR measurements. Here is a picture showing the effect of your guide ventricularizing in the evaluation of an osteal lesion. In the first picture on the left, with the guide ventricularized, the FFR is falsely high and therefore falsely negative. And this is indicated by the presence of a ventricular waveform on both your PD and PA measurements. Once the operator here disengages the guide from the left main, and this is usually best done with a buddy wire, you place a buddy wire down so that you can rail back your guide. And you clearly see now that the FFR, which you previously thought was negative, is clearly positive. Guide side holes are not a substitute for disengaging guide. It is not recommended that you use side holes with osteal lesions, and disengaging the side holes lowers the FFR value, i.e. moves it towards the true value and moves you away from having false negatives without disengaging. The effect is not as large as when you do not have side holes, but it is still not close enough to the true values in papers that have looked at this. This is very basic, but I've seen many interventional cardiologists not administer intracoronary nitroglycerin before FFR measurements. It's in the recommendation for performing FFR. If you do not administer nitroglycerin, you may have a coronary spasm at baseline, and the FFR will be falsely low, and therefore falsely positive with coronary spasm. And therefore, if you administer nitroglycerin, you can make sure that this artifact is not present. In the evaluation of very tortuous lesions, when you place the wire down, you can obviously get pseudostenosis or the Codian effect. And this will result in a falsely low FFR and therefore falsely positive with the wire causing pseudostenosis. In serial stenosis, this is a basic concept, but very important to remember that distal lesions reduce gradients across proximal lesions and therefore lead to a falsely elevated FFR in the segment between lesions, therefore underestimating the proximal lesion significance. It's very, very important to get your wire all the way down and to measure the FFR in the most distal portion of the vessel that you can get to, as the distal FFR is the sum of all lesions. Pullback is useful, but does not avoid the problem that you see here with the FFR being falsely elevated between the two segments. If you use FFR with pullback as well to decide on which lesion to stent, and you decide not to stent the whole segment and you stent the more severe segment, it is still very important that you recheck your FFR after PCI, as it can unmask the significance of the proximal segment. When it comes to microvascular dysfunction, the presence of microvascular dysfunction, which is actually very high in many patients, you should look at it as a corollary of serial stenosis. The presence of microvascular dysfunction increases the FFR value and therefore makes it falsely negative. A similar effect is seen in left ventricular hypertrophy and aortic stenosis. So, to summarize what we've seen so far, when we're deciphering false FFR measurements, can the FFR be wrong? Yes, the FFR can be falsely high, and there are 4 causes of that: physiologic, interpretive, technical, and actual. When it comes to physiologic, this is hemodynamically, obviously this is the correct, this is a true statement, right? If the FFR is high, then it's truly hemodynamically non-significant. Or you could have a small territory, all MIs in the territory subtended, not much viable tissue, or the vessels are small, or the presence of severe microvascular disease. I had one time a thrombus formation within the guide as I was doing the FFR, and what happened was the PD stayed very low, but the PA started to rise very rapidly, and I got up to a FFR of 1.3, and the reason was that a thrombus was actually forming within the guide. And when I pulled everything out and rechecked it, obviously it went back to true tracing. But it's important to recognize these things happening. When it comes to interpretation issues, if you happen to measure in the proximal segment of the vessel to a distal lesion in serial stenosis, then you have a false negative potential there, and also in the presence of diffuse disease, which is a very difficult subset to treat. Technical issues: insufficient hyperemia, the consumption of caffeine, for example, leaving the introducer in after normalizing without. If you dampen the tracing with your guide catheter, if there's electrical drift, or if the pressure transducer is set too high for your PA. Actual false negatives: if you have an acute MI infarct territory, which is microvascular in nature, and therefore that's why the performing FFR in an infarct-related artery is not recommended. If you have severe LVH, or if you have transient coronary spasm. Can the FFR be falsely low? And here there are less causes of a falsely low FFR. One is physiologic, the other technical. If it's physiological, obviously it's truly hemodynamically significant. That's a big cause of a low FFR. Or you could have a collateral supplying vessel, which improves after Cto revascularization, and that complicates your evaluation here. Or if you have the presence of vasospasm. Technically, once again, you can have electrical drift, and pseudostenosis due to guide wire bias, or your pressure transducer is too low. So now, after we've reviewed all these issues, we are going to try to integrate the knowledge and look at the technical issues in FFR evaluation of intermediate left main disease, which hopefully will complement Dr. Bangalore's earlier excellent lecture. Can FFR be used in left main? Importantly, it is important to recognize that DEFER, FAME, and FAME2 actually excluded left main. There have been several prospective trials from 2001 to 2009, however, which showed safety when composite MACE endpoints were compared. And these were of moderate size, right? The maximum study here is 213 patients. And these were summarized nicely in a meta-analysis performed by Amir Lotfi's group in CCI in 2015 that shows that it's comparable. There are many anatomical features of left main disease which can affect your FFR evaluation. We have all seen how complicated these lesions are. They can be ostial midshaft, they can be distal bifurcation disease. Occasionally there's a trifurcation. You may have complex takeoff angles. There is very frequently the presence of downstream LAD and circumflex disease as well. There's a frequent presence of CTOs and a frequent presence of scarred myocardium. These are also sometimes seen in post-Cabbage patients with very complex physiologic interplay. And the data in post-Cabbage patients is really not that good. So FFR can be used in many ways in left main disease. We are going to consider its use in pre-revascularization, the assessing of the significance of the left main disease. There are other ways that it's used in left main, including following main branch stent implantation, which was very nicely addressed by Dr. Kasturi earlier, but we are not going to look at that. FFR, in my opinion, is superior to IVUS in the left main, especially in the world of dichotomous area thresholds. Because specifically it takes into account the effect of additional confounders, such as patient size, and this is significant in Asian populations where the patients are of different physical size. It takes into account the length of the lesion. When you use a singular area threshold, it does not take into account the fact that the lesion might be 2 centimeters long versus 5 millimeters. It takes into account the myocardial mass perfuse and the infarcted myocardium. And there has been a range of deferral thresholds between 6.0 to 4.8 millimeters squared. 6.0 is the Western population primarily. 4.8 was in the Korean population. When it comes to the theoretical issues with FFR physiology assessment in left main, once again, remember the effect of tandem lesions. So when you rule out, you must evaluate as distally as possible because you may, once again, to remind everybody, get a falsely elevated FFR value in the subsegments. And therefore, if there's initial non-significant left main step up and revascularization is performed in the LAD or circumflex, you must then reevaluate your FFR values if you have decided to pursue PCI. There is a theoretical possibility of the effect of a severe contralateral lesion in a vessel that you are also evaluating. For example, if you have a open circumflex but a very high-grade ostial LAD lesion, you can actually cause the FFR number in the circumflex to be falsely elevated. And this was nicely shown in a theoretical model by Bill Fearon's group. And in their model, they did show that in severe disease, the contralateral FFR is falsely elevated. And this is, they then took it on and showed it in humans as well, right? And here, in an animal, this is an animal model where they inflated a balloon in the left main, and you see that the PA is 61. In the circumflex, the PD is 45, so it's 0.74. But when they added a balloon in the proximal LAD, it actually caused the circumflex pressure to be slightly elevated, and therefore it falsely elevated the FFR value, causing a possible false negative. It was important to note, however, in the paper that additional LAD stenosis, although increasing FFR, only occurs when the LAD stenosis is proximal and very severe, i.e. FFR less than 0.5. They then took these observations and studied it in humans. And Reassuringly, though, what they found was that in most cases, contralateral disease does not have an effect on FFR, once again, unless the disease is severe and proximal. So to summarize once again, in the assessment with FFR of left main in the circumflex with a proximal LAD in this cartoon here, in the circumflex, you can underestimate left main disease. If you happen to have your wire only in the proximal LAD in the presence of downstream LAD disease, you can then underestimate left main disease once again. And if you push it distally, you can overestimate left main disease if you were to revascularize your LAD. So remember to always use all the best technique issues. Do not use a guide with side holes. Make sure in osteo lesions, the guide must be disengaged. Use peripheral adenosine, not intracoronary, and this is best achieved once again with a buddy wire so that you can help push the guide out and leave your FFR wire in the measurement position that's most stable. There is one society that has a FFR left main 17 expert consensus. This is not covered by other societies. The German society actually has one. They state that you should measure FFR in both the LAD and circumflex. If one has significant stenosis, only take the actual measurements from the normal vessel. If both have significant stenosis, they say that actually measurements are not possible, which is, I think, a little bit extreme, but you know that tends to be German positions on many things. Dr. Koo had a slightly different take on this from Korea. He says, once again, assess lesion severity in all vessels, left main, non-left main. Measure the FFR at the distal end of the most diseased vessel, and he recommends to do a slow pullback to see where the most significant step-ups are. Measure your FFR in the least diseased vessel. If it's significant, do the pullback. If it's non-significant, once again, consider the influence of contralateral severe stenosis and the possibility of underestimation. If it is significant, though, and there is a CTO in the RCA, consider the influence of the other stenosis, i.e. a falsely positive finding. This is from Euro Intervention 2017. Modi also did a diagram, but I find it a little confusing because it is very complicated, and I think that is reflected within the diagram. Once again, measure the FFR most distally. If it's greater than 0.80 in both the LAD and circumflex, clearly it's not significant, and therefore optimal medical therapy should be chosen. If the FFR is significant in only one of the LAD or circumflex, you have to consider all of the above things that we just discussed. And then at that point, however, you do have to make a decision. Am I going to revascularize downstream to try and unmask the possibility that the left main, but then you are then committed towards PCI, or should I just send in the Cabbage at this point? And if both LAD and circumflex FFR is less than 0.80, we are once again presented with the complex decisions that we have to make with multi-vessel PCI. So to conclude, intracoronary physiology has an important role in intermediate left main evaluation. There is good prospective non-randomized data to support FFR 0.80 thresholds to withhold revascularization. Evaluation is complicated, with a need to be aware of tandem and contralateral lesions effects on measurement. The best techniques must always be employed. And always beware of dichotomous thresholds, yes and no on either side of a single line, and over-reliance on a single testing modality. Patients are complicated. In this setting, sometimes if there is subtlety, I may then drop back and use IVUS to make my final decisions. Thank you.
Fantastic talk, Dr. Conley. Thank you so much. I mean, kind of going back to the basics and do's and don'ts. And many times I think, in our zeal to do complex PCI, I think we sometimes forget the basics. I think you really illustrated the point, kind of went over the basic physiology, et cetera, and everything. So, hey guys, there are lots of questions that have popped up. I know we skipped the discussion after the second one. So if someone does have a pressing thing and needs to leave, please, I understand that totally. But for those that could stay back and kind of, there were some questions specifically to Shripal, so that's there. And then there were some really interesting questions that popped up on the Q&A part too. So one of the questions that was asked is, what is the advantage of nano DK crush versus the conventional DK crush versus mini crush? I mean, since there was kind of a Shripal thing, I'm going to let him field that question.
Actually, Arun, can I add on one part into that question of Shripal, to Shripal?
Sure.
See, actually, Shripal, when you told that your first step in the crushing, you will be taking the balloon from the stent of the circumflex and a normal balloon in the lady, which is kept already. So I did not understand, then you do another crush or not? You don't do a first crush, or will you do a, after that you just taken a stent inside and you did not do a first kiss. There is no other balloon taken for first kiss. Normally in DK crush, you recross the wire and do a first kiss, you know.
Yeah. So in a way, that's one of the advantage of trying to do a nano crush. So in the sense that, so you have wire in the circumflex, wire in the LAD, you've stented the circumflex. Now you're bringing the stent balloon back, and then you're doing kissing there before the crush. The theoretical benefit is instead of both the stent struts falling inwards, you can imagine that if you do this kissing balloon inflation, one of the stent struts is going to go back this way, the other one is crushing inwards. So when you do that, so one of the advantage of the nano crush technique is it's easier to rewire, it's easier to balloon. So most of the times I actually don't do we pull back with the stent balloon, kiss, take the stent balloon and the wire out, crush. And usually the DK crush is exactly what you say, rewire and kiss, and then only do the stent. So I skip that step. And one of the advantages of the nano crush is that you don't need to do that. So you can just put a stent across, you'll be able to easily recross, given the fact that both the stent struts are not crushing inwards. So you'll be able to recross. The ballooning, passing a balloon also becomes easier. So it kind of makes the procedure a bit more faster.
But actually, Shripal, one question is actually, when you don't do a first kiss with the recrossing, without recrossing the balloon, what you do is actually, how can you tell it is mini crush? If your metal is too much, you will be creating a lot of problem there. Do you think it is not?
No, but you're doing pretty much the same thing. I mean, you're still crushing. So, you have to make sure the circumflex stent, the strut is jutting 1 or 2 millimeters into the left main. So you're doing a kiss with the stent balloon and the balloon in the LAD, taking the stent balloon out and crushing it. So you're doing all of those steps exactly the same as you would do the DK crush, the traditional DK crush. The only difference is it's not necessary, and although the classical nano crush technique is still you have to recross and do a kissing balloon before you put in the LAD left main stent.
The opening created by the first kiss will not be there. So the recrossing of the wire, that is actually the advantage of the DK crush as such. The first kiss will help you for the second recrossing of the wire after putting the stent. But that chance will be lost by your technique. Do you think so?
No, it's actually, you're right. But the fact that you're kissing with the stent balloon will make sure that you can imagine if this is the stent and if you're crushing before doing that nano kiss, the stent can collapse this way when you're crushing, right? Yeah. So the lumen is not that big. When you're doing the technique I'm suggesting where you actually take the balloon back and kiss, this part of the stent will go this way. So now you have this, and when you crush it, you have something like this. So the orifice of the side branch is something like this, where it's not this way, it's actually this. So you can imagine, so it's easier to recross and also pass the balloon in the proximal part of the strut if you do the nano crush.
Do you have an OCT imaging, and in that, whether you have a demonstrated OCT imaging, and it is equivalent to that, or it is you have an imaging study? Just
I don't think there is only one study published based off of the nano crush technique, and they have shown excellent results. It's comparable. It was an OCT study, and they showed the results are very similar.
Okay.
No, thank you guys. Like, that was a very interesting discussion. I think Dr. Sengutuvelu had something to say to add on to this. So maybe one more comment about this, because I think we have a couple of questions still. I'm happy to stay back as long as you guys will, but
No, I just wanted to tell Pratap that it's just a step like how you do a tap. When you put a stent in the tap, you pull the stent balloon and do a kiss. It's just one small additional step is that, but it's not going to change anything. It's going to improve after all. So it's not going to worsen your wiring or anything. That's what I want to tell. Right.
So guys, there's you guys can, okay, there's one other question. Strategy for difficult side branch recrossing. Dr. Sridhar, do you want to take it?
Yeah, if you want to difficult side branching, sometimes what happens, always you have to do the part. Remove the side branch wire as early as possible. What happens if you don't do proper part? Whenever you put the wire can go through the stent struts. It may be abluminal. So that is one of the advantages of the OCT. You can see very clearly, is it luminal or abdominal? Are you going through the proper strut like a mid or distal strut? That's very important. Another thing, sometimes if you are disengaging the wire, if some left main struts are projected outside, when you are putting the wire can go through the struts. Again, it's very difficult to cross. So already if you have a LED wire in the true lumen, take that pin, take a dual lumen catheter like a Sasuke, or you can take the Crusade, and over that you can put the another wire. You are very clearly you are in the true lumen. That time you can access the side branch, you can enter into that one. If you don't do proper part, the orientation of the side branch opening is not proper. So that that should be with the proper sizing of the balloon. Suppose you are having a 4.5 mm left main, you have dilated with the 3.5. That is not adequate. You take the appropriate sized part balloon, make a proper. Don't extend beyond the carina. It should be before. If you go beyond the carina, it compresses the carina. Again, side branch pinches. Again, difficulty in crossing that one. So one is, and at the same time, so when you are pulling the balloons also, you should be very careful. It can suck the catheter. It can cause the longitudinal shortening. Again, that can cause difficulty in crossing the wire. These are the important steps to cross the side branch.
Great points. Hey, there's another interesting question, maybe for Shripal or Dr. Pratap, I guess. So in left main bifurcation, 2-stent PCI, should stenting extend to the ioto-osteal segment? I guess Shripal gave the left main talk, so I'm going to let him first dibs.
Yeah, so I think it really depends. I think that's why intravascular imaging is extremely important. The short answer is it really depends on whether there is a disease there or not. If there is no disease and if it is very distal left main, I don't see any big advantage of coming to the aorta-ostium. And again, you have to make sure that the landing zone is in a disease-free place. And if you still have 50% plaque, for example, in osteal left main, it's better to cover it. If you don't have it, and this is the reason the IVUS can help you plan with a decision what to do.
I think
can I just add to one to it?
I have a point to add on that. If the LMCA is less than 8 millimeters, definitely. Actually, that there is a pot chance here. That's the most important point here. And sometime, when you do an IVUS imaging, or OCT imaging, you may see that there is a 20% plaque and you may stop in between the LMCA part. These type of patients usually come back with the restenosis and osteal LMCA. What is your comment, Shripal?
Yeah, I think you said the most important thing. I mean, for me, it's the size of the part, right? I mean, so you have to know what size of balloon you have. For example, if you have usually I go 4 or 5 or a 5.0 for the left main. You have to make sure that you have a 6 or an 8, and the stent cannot be shorter than that. So you have to absolutely make sure you have covered the left main enough for a part. And if you do that, I think it really depends on how much disease you have in the ostium, and you should be okay.
Now, I would like to also the importance of the protrusion into the ostium. When you don't, it's not mandatory. The question is whether you have to mandatorily stent the ostium. I would probably agree with both of you that you don't have to do it. And when you do it, you have to remember that there is a possibility of guiding catheter hitting it, causing longitudinal shortening. And that particularly the case with Shripal showed, with the Promed stent, he showed excellent results, maybe because he did IVUS to make sure there was particularly using a Promed stent. he showed excellent results, no longitudinal foreshortening. So that's important when you consider doing osteal stenting.
And actually, Sripal, I wanted to tell one point. If you are actually taking a lesion up to nearly 9 millimeters in the LMCA and you put a stent and you are actually having a 3.5 millimeter stent, you inflate with a 4.5 balloon, you may create a foreshortening and that create 1 millimeter less, Naturally, that can be a problem later on. That is actually the issue which nobody addressed on.
Yeah, I think that's very important. Depends on the relative size of the left main and the stent you're taking, and the relative shortening is very important. I think that's why you have to understand the dynamics of the stent you're using, and also take into consideration specifically if it is a 3.5 going up to 5.0, you can imagine there is going to be shortening.
Yeah.
Great points. Guys, another question on IVL versus Rota. I think you guys have had it in the US for a little bit longer than us. So you want to take it, or Dr. Sridhar has done a couple of cases. I think Dr. Sengutuvelu has also done a couple of cases that I know of. How are you guys doing it? And Dr. Pratap, I'm sure, has also done a couple of IVL cases. So maybe I'll have Sripal take it first, and then each of you can maybe add a comment or add on to that.
Yeah, just to keep it short, I think the other guys can weigh in more. Here, it's still investigational, right? We just finished the trial. So we did it as part of the trial. The peripheral IVL, of course, is available. Right? And many a times, some of us have been using it off-label, but the coronary IVL, we just finished the trial.
You can give more pulses, though, with the peripheral or something, right?
Right.
So because here it's all about economics. If you can get more bang for the buck, we'll take it.
Yeah.
So, Dr. Sridhar, you've been kind of quiet. So, I know you've used IVL in your cases. So, how are you now that that's available?
IVL, I prefer particularly when I predict some slow flow, no flow, very high. Particularly Rota, the disadvantage is slow flow, no flow. Very bad LV dysfunction, such type of patient, unstable patients, renal failure, where you predict more of diabetic, diffuse disease. That type, but only one disadvantage with IVL, it is not suitable for balloon uncrossable lesions. That is one of the disadvantages. Many times severe calcific lesions, and if balloon uncrossable, Rota is the only answer. Though laser is there, it's not available in India. But when you are having a very tough undilatable lesion, when you can cross with the balloon, IVL. One of the advantages of IVL over the Rota, it can attack even deep calcium, whereas Rota cannot go to the deep calcium, even medial calcium deep also it can penetrate. You compare to calcium nodule, it can come, the Rota, sometimes it may miss the calcium nodule, like orbital atherectomy, and IVL scores over that. The IVL, because it can produce the sonic rays 360 degree, it's a better choice in CN particularly. And at the same time, the dissections are low, slow flow, no flow low when compared with the Rota. Another thing is angulated lesions. You can use the guide liner, you can push, but more than 45 degrees angle, definitely Rota is not choice. Only halfway Rota is there. You can only proximally do and subsequently do the balloon and the dilatation. Even the advantage of the IVL, side branch, you don't lose the side branch access. Why you can't. And there is one recently some published case reports are there. You can put the side branch, NC balloon and IVL in the main vessel. And if you give the IVL therapy, it can transmit the sonic rays to the side branch balloon also. It can modify. So recently we did one left main case, LCX, IVL and LAD, NC balloon. And I was showed a really very good result. So that way, compared to Rota, you have to pull back the wire. So side branch access, when difficult to angulate, tortuous vessel, in such case, I think if balloon crossable lesion is there, take the guide catheter, guide liner, and push the IVL. That's the better choice in such circumstances, I feel.
Sridhar, I just wanted to tell you very importantly, which patient will get a slow flow, no flow in a rotability is basically balloon uncrossable lesion. When you have a balloon crossable lesion that means that much plaque will not be there to create a no flow or reflow. That's a very important point. And I actually feel that IVL is definitely better in a patient with a tortuous anatomy more than 45-degree angle where a rota can create a complication because of the guide wire bias. That is the only situation where number one. Number two, if you wanted to create a big lumen, especially with a lot of deep calcium, otherwise I don't know whether after rota cutting balloon will not may produce an excellent, almost a good result like this. But IVL definitely has a choice in a large vessel where rota will not be touching even the vessel, where it is a large 4 millimeter vessel, a good diameter. Even a 2 millimeter rota, which is available, that is the largest size available in India, will not touch the vessel. That situation, again, IVL has a role.
Actually, slow flow, no flow, not depend upon whether crossable or uncrossable. It all depends upon the calcium bulk. If you are debriding more and more, diffusing calcified, you are producing more debris. Each debris size, if you see, the rota produces almost 7 to 8 microns, whereas the arbitral atherectomy, 2 microns. So that's the reason arbitral atherectomy MACE rate is low. Our rota never produced any low MACE rate compared to arbitral atherectomy. That's the reason MACE rate is much lower in arbitral atherectomy. Why? Because the debris what arbitral atherectomy produces only 2 microns. So that's the reason. And central flow flushing, that is also there. Well, open and see, the disrupt study has shown very clearly slow flow, no flow, dissection. These are all low compared to rota.
Good point. I just want to add two other good indications for IVL. One is if you have a calcium in the left main, it's very difficult. For example, if you have a max use of 2 millimeter burr, you can't still completely debulk the left main to have a good expansion of the stent. So using an IVL like a 4.5 balloon is a good option to debulk calcium in the left main. The second good indication is a underexpanded stent or a heavy new atherosclerosis, a calcium behind the stent. For that, again, IVL scores over rotablation, which has a good effect on expansion of the stent.
Sengot, what I accept it. But actually, the most of the time when you take a rotablator, we take a vessel which is not crossed by an IVUS catheter, where you will be in trouble. And IVL definitely can contribute and it give an extra advantage over rotablator. Most of the cases,
absolutely. All of us agree that IVL is a great tool for deep calcium. Yeah.
Actually, ISR neoatherosis is the definite indication because the deep calcium, the paleoatherosclerosis, that is also contributing factor for the ISR progression. That is also one of the, because it can, if you do the stent ablation, the chance of the burr entrapment is more when underexpanded stent, though some case reports are there for stent ablation. But IVL is the better choice in such circumstances. Even
Dr. Sripal, without the IVL, how do you manage these calcified left mains when you have large left mains? How do you get the stent expanded?
Yeah, so that's definitely, I mean, I completely agree with all the discussion. I mean, IVL is very attractive for a number of reasons. So, so one of the techniques that I follow is, the Japanese have shown this very elegantly in their OCT studies. So if you use a 1.5 burr, I usually start by around 180 RPMs. The final run I take is, I slow it down to 110, 120. It's the final one. And they have shown that if you do that technique, you actually increase your size by a quarter. So 1.5 becomes 1.75. I've had only one case where I had to upsize from a 1.75 to a 2.0. But, if you slow it down, you actually get better gain. And of course, I think this is why I was showing in my case, it's critically important to use a 1-to-1 size balloon before you throw in any stent. Because specifically for left main, you never know, sure, the rota went through, but, you're putting in a 4.0. So at least take a 3.0, 3.5, make sure that it expands nicely before you actually throw in a stent.
Interesting. The other thing is ultra high pressure balloon called OPN balloon, which also sometimes helps in these calcified lesions in large left mains. But of course, it carries a risk of rupture, particularly if you don't size it properly, you tend to oversize it.
Great points. I mean, I think, before IVL, the only thing we had to get to tissue beyond the stent was laser, which we didn't have in India anyway, so it's just in the US. So, I mean, fantastic discussion, pretty much concur with everything. So one of the other questions that has come up is RFR versus FFR. Dr. Sengood, you do a lot of physiology. Do you want to take it?
Yeah, sure. See, RFR is a resting full cycle ratio developed by Abbott. We know that FFR is an average PD by PA throughout the entire cycle, and which is with hyperemia. So RFR is without hyperemia, non-hyperemic agent. Actually, it's similar to IFR. So IFR has been the first agent. It has been a wave-free period in diastole where the resistance is low, and they said both the PDPA at that level is very, and they found that recent studies have shown very good results with IFR. So RFR is compared to IFR and found to be almost equivalent and has the same cutoff value as 0.89. And but there are some studies. This year in February, there was a study published in Heart Lung Circulation saying that advised caution in using RFR in left main assessment. So we have some controversies, but on the whole, we have to consider RFR as equivalent to IFR, and the cutoff value being 0.89. And it's one of the biggest advantages used in serial lesions. Unlike FFR, which you need a adenosine infusion, RFR, all the other resting indices have less interaction in these tandem lesions, and the interference between the two lesions are less. So using RFR pullback for tandem lesions will help to identify the exact significant lesion much easily than FFR.
Great points, guys. Hey, there's one question about does anyone preferentially use FFR for intermediate left main lesions, or do they pretty much go with IVUS or one of the other imaging modalities? Anyone? I mean, I think
I can make it. Arun, see, as discussed nicely earlier during the talk on FFR, the cutoff in Asians and the Western population for left main MLA is different. Right. And our cutoff is 4.5, whereas the Western cutoff is 6. So when you use imaging like IVUS to assess the left main, when you have a clear cutoff, you have less than 4.5, we have to revascularize. So if you more than 6, you can leave it off. But when you have an intermediate zone, 4.5 and 6, then comes the role of physiology, without which it's very difficult to make a clear decision. So, and then in that situation, FFR is very useful. And there are difficult situations, as discussed in the talk. We have to be very careful when you have some other lesions in the LAD. You have to see whether there's a lesion in the circumflex. So there are challenges in assessing FFR in left main, but it's very useful when you have an intermediate assessment in the imaging.
Guys, if you have comments, please.
I wanted to tell you that.
Yeah, sure. But I do want to also tell you guys, if anyone has to leave, thank you so much. I know you've all extended beyond your time. Really appreciate it. So I don't want to be disrespectful. We still have I think we have more than 80 participants. So if you can stay back and kind of have this discussion going, if there are more questions, etc., please. But if someone needs to go, I completely understand. Thank you again. Really appreciate it. So I'm sorry, Dr. Pratap, please go ahead.
Sengood, we have to tell that even an FFR can give you an intermediate value between 0.75 to 0.8. Then again, you have to do an IVUS imaging or OCT imaging to understand exactly what is it. That again, the anatomy comes there.
Yeah. See, if you ask me, over physiology or imaging, if you do like non-left main lesions, it's clearly, we can look at only physiology scores. Whereas in left main lesions, you have a cutoff, both has support. You have data for cutoff values for imaging. So it can be supplemented in either way in intermediate results.
Dr. Sridhar, anything to add to that?
In true bifurcations, like a significant LAD, LCS lesions, to assess really left main needs or not, take the 4.5 square mm and 6 cutoff point. In between needs FFR, definitely, to prove that left main is significant.
Fantastic. I think there was one question about Shripal's case, so I'm going to wait for him to get off the phone. So guys, like in general, right? I mean, is there anything else that you want to add on to the whole physiology imaging conundrum? Like, the old teaching used to be like, okay, physiology for assessing if something should be done. And I completely agree with Dr. Sengutwelu, like, imaging and physiology, especially for left mains, and imaging really to kind of optimize how you do it. I mean, I think we also touched upon calcification. Is there any, like, with all your experience, Dr. Pratap, anything in particular that you want to tell the audience before we kind of call the curtains on the session today? You're muted for some reason.
It was a wonderful program. I think Shripal's talk was very good, and it was there are a lot of points he stressed. I think now it is 9 o'clock, 9 plus.
So, yeah, let's just closing comments, guys. Yeah.
Yeah. Thank you, Arun, for.
Thank you so much for taking
the last message.
I'm sorry.
Shripal, you wanted to ask Shripal? He's ready.
Yeah. Oh, yeah. Shripal, there was a specific question about your case there. I don't know if you can see it in the Q&A. So there was one question about where was the MI on the ECG and echo in your case?
Yeah, so that's a great question. So, so this patient's troponin was greater than 150. If I remember correctly, I think he had some kind of IVCD. So the EKG was not diagnostic. The echo showed wall motion abnormality in multiple territories. So, and even the right, I mean, it wasn't clearly it didn't look like the culprit. I mean, it wasn't thrombotic. We had to use CTO wires to cross it and so forth. So the short answer is, I don't think it was, something may have transiently closed, but it wasn't very clear.
Which happens a lot, right? I mean, sometimes you just don't get it.
I don't. If I do the case, actually, I do as a stage procedure. I do an RCA first and then LMCA after 2 days because we don't use Imbala, and that is so expensive in this part of the country.
Right.
Oh, in this particular case, yeah, I know we did think about it. I mean, this was actually now 14 days after his MI. So it wasn't the typical acute MI cardiogenic shock on that day. If it were to be the case, I agree. I mean, we tend to do the culprit only first and then bring them back for stage. And of course, we rarely go after CTOs during a cardiogenic shock based on the, the complete the shock trial for shock patients. So, yeah, so this was different. I mean, although it was shock, but it was 14 days out and he was relatively okay on dobutamine.
All right, guys. Thank you. Dr. Sengutz, anything for the audience?
Just one final question I would ask Shripal. About this, the interesting aspect of the DK crush data, which you just recently was published. You think there is any bias? You look at the European data and look at the Asian data. The Asians more favor DK crush, and the Europeans still favor a kind of provisional and more of a culotte. So this controversy is still going on, where whenever you talk to somebody in the European Bifurcation Club, they're totally against DK crush. But more of the Asian data is coming like this. So what is your thought on that?
Yeah, I would say, and of course, many people can, put forward their own anecdotal data, but randomized trials, I mean, now showing consistent signal for DK crush being superior. That being said, the superiority is mainly to prevent repeat revascularization. So for me, there is much stronger data for DK crush from randomized trials showing outcome benefit. If you look at OCT optimization, the number of studies actually showing that the main vessel, the carina, and the bifurcation actually is much better optimized with OCT, and flow loop models are showing the same thing. So, I do place more faith in it. I mean, it may be that, technically it needs, there is a learning curve to it, and maybe that's the reason people are pushing back against it, but at least the data seems to be in favor of DK crush.
Dr. Sridhar, just one other question. I'm going to, and we'll kind of call it curtains after this, guys. OCT does for left main disease, cutoffs. So if Dr. Sridhar is still on, there's one other question that has popped up. People still have a lot of questions.
Okay. If you see, compare with the IVAS criteria, the OCT parameters are 10 to 15% lower. So you have taken 4.5, 10 to 15% lower, almost like a 3.8 to 4 left main if you use the OCT criteria. So that is one of the criteria, but even the guidelines have shown very clearly reference diameter, take reference diameter, is it more than 90%? But at least it should be more than 80% as per the recent ESC guidelines. And anywhere the mean stent area should be more than 4.5 square mm, and even landing zones also should be more than 4.5 square mm. So anywhere it should not be lower. If you are using IVAS, it is a 5.5 square mm. If you are using the IVAS OCT, it should be 5 square mm.
For
So
non-left main.
all the OCT values are 10 to 15% lower compared to IVAS values. Suppose 4.6 is there, another 10 to 15%. That means almost 5.5.
That's for non-left main you're talking about. The
Anyway,
question was about left
compared
main.
to OCT criteria, OCT parameters are 10 to 15% lower compared to IVAS diameter. So non-left main 5.5 and this one non-left main 4.5. Suppose assume that you are doing a left main stenting. Proximal left main is 13 square mm. And if you are stenting the distal, at least you should achieve 10 to 12 square mm, because it should be more than 80% of the proximal reference diameter and 80% of the distal reference. You take the proximal or distal. Otherwise, like a Illumini study, proximal half proximal reference diameter, distal half distal reference diameter, and see that at least you are achieving 80% of reference diameter.
Gentlemen, really appreciate your time, but I think all good things have to come to an end. We have extended by an hour. So thank you again. Heartfelt thanks. Really appreciate it. Great discussion. I mean, I'm sure you can ping any of the panelists or speakers offline if you want to continue. So I'm just going to put in my number in case someone wants to really have some question answered. But thank you so much again.
Thank you, Arun.
Thank you, guys. Thank you.
Thank
Thanks,
you.
Dr. Sridhar. Thanks, Shripal, Pratap.
Thank you.
Good night, everyone.
Thanks. Bye. Thanks, guys. Bye-bye.